Hi, this presentation will explain cardiac chest pain in acute coronary syndromes. We will be talking about the pathophysiology, the risk factors, the signs and symptoms, the diagnostic testing, the medical management as well as nursing management, the medications management, and complications. Thank you. Acute coronary syndrome is a disease related to the deterioration of the atherosclerotic plaque that is made of fat, cholesterol, calcium, and other substances, which would all build up in artery walls. Once the staple plaque ruptures, it stimulates platelet aggregation and vasoconstriction to form a thrombus, which can partly or totally block the blood flow in arteries, leading to ischemia. Angina is a common chest pain symptom rather than a disease. It underlies narrowed coronary arteries and temporary deprivation of blood and oxygen to the heart. Therefore, the heart tries to pump harder and faster to increase the blood supply to meet the body's demand. Unstable angina may worsen and develop to myocardial infarction if treatment is delayed. On the other hand, cardiac chest pain in ACS is due to MI, include ST segment elevation myocardial infarction and non-ST segment elevation myocardial infarction. MI causes irreversible damage to the myocardial tissue. It occurs when a thrombus from the ruptured plaque blocked the blood flow, resulting in necrosis and ceased contraction of the heart in the area blocked by a thrombus. The cardiac cells can survive 20 minutes in such condition before they become dead cells. Depending on the degree of embolism, it can take up to 12 hours for the heart to become completely necrotic. Several studies have assessed the role of blood pressure levels in the prognosis of patients with acute coronary syndromes. Pathophysiologic links of hypotension to acute MI include endothelial dysfunction, autonomic nervous system dysregulation, impaired vasoreactivity, and a genetic substrate. A history of hypotension is highly prevalent among patients presenting with MI, and some but not all studies have associated with a worse prognosis. Arterial hypertension is a well-established cardiovascular risk factor, and blood pressure control has largely improved the prognosis of hypertensive patients. Some data support that low level of admission and in-hospital blood pressure may indicate an increased risk for subsequent events. Risk scores used in patients with MI have therefore included BP levels and a history of hypertension in their variables. Smoking is a major cause of cardiovascular disease, CVD, and causes approximately 1 of every 4 deaths from CVD. Even people who smoke fewer than 5 cigarettes a day may show signs of early CVD. The risk of CVD increases with the number of cigarettes smoked per day and when smoking continues for many years. Smoking cigarettes with lower levels of tar or nicotine does not reduce the risk of cardiovascular disease. Atherosclerosis, in which arteries narrow and becomes less flexible, occurs when fat, cholesterol, and other substances in the blood form plaque that builds up in the walls of arteries. The opening inside the arteries narrows as plaque builds up, and blood can no longer flow properly to various parts of the body. Smoking increases the formation of plaque in blood vessels. In diabetic patients following myocardial infarction, the rate of mortality and reinfarction are substantially increased. It has been shown in many studies, out of which many deals with the subpopulation of diabetics. In general, these studies have dealt with mild myocardial infarction, while the study in this issue explains an increased mortality across the spectrum of acute coronary syndromes. with increased mortality rate at 30 days for patients with and without ST elevation. Dyslipidemia is one of the major risk factors which is widely prevalent in patients with ACS and is more prevalent in males than in females. Adoption to healthy lifestyle behaviors was associated with a lower risk even among obese individuals. The prevalence of overweight and obesity is increasing in most industrialized countries. Obesity is associated with an elevated risk of ACS in both healthy and less healthy subgroups of lifestyle behaviors. A high risk of coronary artery disease is among the well-established adverse health effects associated with excess weight. Hypertension, hypercholesterolemia, and diabetes are among the clinical conditions that are important mediators of this association. Thus, obesity is an appropriate target for primary prevention efforts because its modifications has the potential to influence several important clinical conditions along the causal pathway. People who had family history of CAD are at greater risk of developing acute coronary syndrome. Men and women aged less than 55 years showed more signs related to heart problems. In comparison to other populations, people with family history of heart diseases were more likely to develop heart problems. Chest pain in acute coronary syndrome is usually defined as aching or tightness to the chest. When the fats deposit into coronary arteries, it forms a clot or a rupture to the blood vessels sometimes, blocking the nutrients and oxygen to the heart and causing the pain to the individual. Often the pain moves down to different parts of the body, from chest to shoulders, arms, upper part or abdomen, neck, back or jaw. Without enough oxygen and nutrients going to the heart and blood vessels, our body is not able to make enough energy, causing fatigue in individual's body. Sweating or diaphoresis is often called one of the most common symptoms in patients who has cardiac chest pain. This happens because in the initial stage of MI, catecholamines are released by myocardial cells, causing vasoconstrictions of blood vessels and sweating in the body. When the catecholamines are released by the myocardial cells, the heart rate and blood pressure increase at first, and after a while there is a drop in the blood pressure due to decrease in the cardiac output. Normally, in case of acute coronary syndrome, individuals complain of pressure or ache around their chest areas, causing them to feel out of breath or breathless. When there is a blockage of oxygen supply and nutrients to the heart, there is not enough oxygen going to the lungs, making the individual out of breath and making patients feel really dizzy and they are almost fainting, which makes them feel to vomit. Due to death of myocardial cells, it triggers systematic inflammatory process causing elevation in body temperature. It can go up to 38 degrees Celsius. After MI takes place, serum glucose levels frequently raise after lipolysis and glycogenolysis occur. After these neutrophils and monocytes have cleared the necrotic debris from the area of injury and collagen matrix eventually appears in as a scar tissue and takes place. For patients who have cardiac chest pain, the key tests used to determine if they have an UA or MI are the electrocardiogram and cardiac markers. The 12-lead ECG is the first tool to distinguish between UA, STEMI, and NSTEMI by looking for the modifications of the QRS complex, the ST segment, and the T wave. A STEMI ECG would indicate a ST elevated segment and a abnormally wide and deep pathological Q wave if the infarction is severe and the area affected is large. This often indicates a complete coronary occlusion. A NSTEMI graph will display a ST depression along with T wave inversion, which are indicators of ongoing myocardial ischemia. The graph may also display an abnormal Q wave. If an ECG shows anstemy but the troponin levels are normal, it will be categorized as unstable angina and treated as an impending MI. Cardiac-specific troponin is one of the important cardiac markers in diagnosing MI, especially troponin T and troponin I. Troponin test is usually performed when patients experience chest pain or other symptoms and side effects that may be associated with ACS. It is a blood test that used to determine coronary artery failure, stable angina, and unstable angina by measuring the level of the group of proteins in the blood, including troponin T and troponin I. These proteins are released when the heart muscle is damaged and become necrotic after MI. The damage to the heart is proportional to the amount of troponin T and I in the blood. The change of troponin T and I levels occurs in 4 to 6 hours, with a peak of 10 to 24 hours after AMI, and return to the original level within 10 to 14 days. For troponin I, a positive result which greater than 2.3 microgram per liter would indicate myocardial injury. Creatine kinase MB is an enzyme in the heart and skeletal muscles. When myocardial injuries occur, this enzyme is released into the blood. It also can be used to assist with diagnosing acute MI by referring to the outcome intervals. A normal range for men would be 60 to 220 units per liter. However, it's not commonly used as troponin as it takes longer to appear. Other tests can be performed such as chest X-ray, echocardiogram, cardiovascular MRI, and coronary catheterization. Percutaneous coronary intervention (PCI). Primate PCI is for emergency use without previous administration of thrombolytic agents and antiplatelet agents. It is the first-line treatment for patients with confirmed MI. Facilitated PCI is defined as pharmacological treatment administered prior to planned PCI. Rescue PCI support the facilitated PCI if pharmacological treatments failed. It is also used to determine if further procedure is needed, for example, bypass surgery. A deflated balloon-tipped catheter with a stent is inserted from artery in groin to the site of blockage. The balloon is inflated when it reaches the blockage, which allows the stent expands and locks in place. Then the catheter is removed. Thrombolytic therapy is an alternative option when PCI and catheterization lab is not available. It should be given ASAP, most ideally within the first hour, preferably 6 hours after the onset of symptoms. All thrombolytic drugs are given intravenously in a single bolus or boluses administered 30 to 90 minutes apart. Thrombolytics always come with risk of bleeding. Coronary artery bypass graft surgery is a procedure that has higher risk, as involves opening of the chest cavity and cardiopulmonary bypass (CPB). During the procedure, heart is temporarily stopped. Blood is diverted to circulated and oxygenated in a heart-lung machine. In CABG, the internal mammary artery (IMA) is most commonly used. The proximal end of the artery remains to the origin. The subclavian artery, the distal end of the IMA, is attached to the coronary artery distal to the blockage. The long-term patency rate for IMA grafts is greater than 90% in the first year post-surgery. However, post-surgery complications, for example bleeding and infections, may occur. This may increase with age. In nursing interventions, A to G assessment is always a must. Assess oxygen saturations, measure respiratory rate, be aware of dyspnea, which is an early sign of heart failure, and check if the patient is speaking in full sentences, and oxygen therapy. Check for peripheral cyanosis, which may indicate there is a limited supply of oxygenated blood, and check blood pressure and heart rate, which is also an early sign of heart failure. Use GCS to assess levels of consciousness, as patient could faint because of severe pain. Check pupils, which may indicate neurological abnormalities, as arrhythmia disrupt the heart to regulate the process of blood pumping, and myocardial ischemia and cell death prevent the heart to pump out sufficient oxygenated blood to circulate through the body, e.g. the brain, and thrombus may also travel through the blood flow and enters the brain. Patient may be on IV thrombolytics or morphine. Use VIP score to assess if the IV site is healthy and no signs of phlebitis. Assess abdomen. A swollen abdomen may indicate internal bleeding, which could be caused by the use of thrombolytics and anticoagulants. Patients with ACS may experience nausea and vomiting due to severe chest pain. Monitor fluid balance, assess if they are tolerating their diets and fluids. If they need a CABG, ensure they are new by mouth. Monitor glucose and administer insulin as per med chart. Pre-diabetic or diabetic patients may do exercise to reduce BGL. However, in the context of ACS, exercise should be limited and rest is much needed. Diabetic patients may develop diabetic neuropathy and suffer loss of sensation, particularly to pain. Therefore, they may not report any chest pain. ECG as well as bedside cardiac monitors should be implemented for patients from ER to ICU to step-down general unit to identify arrhythmia, ST elevations, or reinfarction. If oxygen therapy is ordered by the doctors, assess respiratory rate and signs of respiratory distress. Sit the patient in high floor position. Apply nasal prongs or non-rebreather mask. Assess nostrils conditions regularly and moisturize nostrils. Assess pain levels using pain scale from 1 to 10 and provide analgesics, for example, glycerol nitrate and morphine. Monitor respiratory rate and signs of respiratory distress if morphine is used. Reassess pain levels to see the effectiveness of the analgesics. Some patients may not verbally report their pains, and therefore we can monitor facial expressions, for example, grimace, and symptoms like elevated heart rate. Create a comfort environment that allows patients to rest. Our body relaxes and would require less work from the heart while sleeping and resting. We may implement relaxation techniques, for example, play music. We explain to patients in plain words what is going on, what are the treatments for, and reassure patients that they are looked after. For example, let them know where the call bell is. Medications from different classes can help to treat ACS. Aspirin is the only medication in the NSAIDs group that has significant antiplatelet properties. It inhibits cyclooxygenase, which produces thromboxane A2, a potent platelet activator. It was found effective in reducing death incidence in MI and the progression to MI and mortality in patients with unstable angina. RNs needs to make sure aspirin is stopped 7 days before planned surgery to reduce the risk of bleeding. Redaplase is a tissue plasminogen activator, TPA, which helps plasminogen transform to plasmin. Plasmin then degrades fibrinogen and fibrin, the key components of thrombi, breaks the fibrin meshwork and dissolves blood clot. Medications of this class have an advantage which activates plasminogen that only exists within the clots, therefore minimize general hemorrhagic episodes. In patients with acute MI, redaplase should be given within 6 to 12 hours after symptoms develop. The common side effects are bleeding and arrhythmia. Therefore, cardiac monitors should always be activated. GCS may also be used to detect if there's any internal bleeding. Heparin acts by enhancing the function of the antithrombin 3, a natural inhibitor of coagulation. It stops the activated factor XA and thrombin. Heparin can also be used when anticoagulant actions are needed outside the body, like the heart-lung machine used in CABG. Thus inhibits formation of thrombi in the machine and prevents thrombi travel through the circulation back to our body. Low molecular weight heparins are a fraction of the size of heparin. It also binds to antithrombin 3. Enoxaparin can be administered twice daily. Low molecular weight heparins are less likely to cause thrombocytopenia compared to heparin. Glyceryltrinitrile is used to treat unstable angina pain in the context of ACS and improves coronary blood flow. It decreases cardiac preload, the volume in the ventricles at the end of diastole, and venous return. It also decreases the afterload, the pressure that the ventricles need to open up the valves to pump blood to the rest of the body, and reduce pulmonary vascular resistance. These actions decrease BP, relax the heart and reduce cardiac workload, increase coronary blood flow and oxygen supply to the myocardium. Common side effects are nausea, syncope, facial flushing, and reflex tachycardia triggered by baroreceptors if BP dropped too much. Glycoprotein 2B3A receptor is an important integrin as it intervenes platelet aggregation, similar to an opioid antagonist which bind to an opioid receptor and block opioid activations. Tirofiban binds to glycoprotein 2B3A receptor. Prevent fibrinogen binds to this receptor, therefore blocking platelet accumulation. Tirofiban can only be given via IV injection and may be administered with heparin or low-dose aspirin to treat UA and MI. Morphine provides pain relief of moderate to severe pain as well as sedation. It also acts as a vasodilator to reduce cardiac preload and myocardial oxygen consumption. When morphine encountered with coumarin anticoagulant agents, for example warfarin, it would enhance the anti-clotting activities. Morphine causes hypotension and, more commonly, respiratory distress. Moderate doses could significantly reduce self-ventilation and should be used with caution in patients experiencing hypoxia. ACS may cause blood pumping problems such as heart failure, hypotension, and shock development. If more than half of the heart tissue is damaged or dies, the heart is usually unable to function properly and can lead to severe disability or death. An abnormal rhythm may occur when MI damages part of the heart's electrical structure. Sometimes a part of the heart triggers a heartbeat problem, so the heart rate can be too slow, which is bradycardia. During dilation, areas of the heart muscles that have poor blood flow but have not yet died may be very agitated. This restlessness can cause heart rhythm problems such as ventricular tachycardia or fibrillation. These rhythm problems greatly interfere with the heart's ability to beat and can lead to cardiac arrest. Post-myocardial infarction syndrome, it is also called Dressler, which is a form of pericarditis that develops 10 days to 2 months after a MI. A ruptured diaphragm can cause too much blood to be diverted to the lungs, leading to fluid buildup, pulmonary edema. Aneurysm can be surgically removed if heart failure or an abnormal heart rhythm occurs. Blood clots may block parts of the brain or the blood supply to the different organs.